students, myself DeAngelis Singh, Senior Tutors, School of Nursing, Sanskriti University, Mathura. So today we are learning about the abortion. So firstly we will see the introduction of the abortion. So what is the abortion? So many people aware of this term. So we will see the what is the abortion. So abortion is described as the expulsion of the product of the conception product of conception before the embryo or fetus is viable means it is the living organisms, and any interruptions of human pregnancy prior to 22 weeks, if the pregnancy expelled before the 22 weeks, it is called abortion. 22 weeks of gestation or the delivery of the fetus weight less than the 500 gram, if the conceptive material, in other words we can say the embryo of the the weight of the embryo of the fetus is less than 500 gram or 500 gram, and the week of the gestation is 22 week of gestation. If the 22 week of gestation or less than 22 weeks of gestation, it can be we can call it as a abortion. So next we will see the definition of abortion. Sorry. This is the definition of abortion. According to WHO, abortion is expulsion or extraction from its mother of an embryo or fetus weight less than 500 gram or less than, or when it is not capable of independent survival. That is the 500 gram of the fetus development to attain the approximately at 22 weeks of the gestation. Means it's 154 days approximately, then all gestation. Okay, this is the definition of the abortions. There are two terms you can see: weight less than 500 gram and before the 22 weeks or 22 weeks of gestation, we can say. Then next we will see the incident rate. The 10 to 20% of all clinical pregnancies and 75% abortion occur before the 16 weeks of gestation, and rates vary with the maternal age. Also it the causative factor, and also high in women with past miscarriage, means recurrent pregnancies, we can say. Then next we will see the classification of abortion. There are mainly, it is two types. Abortion divided into two types. First one is the spontaneous and second one is the induced. And spontaneous is also divided into two types. First one is the isolated or sporadic abortion, then recurrent abortion. If the abortion is individual abortion occur, if the recurrent one by one abortion occur, this is termed the recurrent abortion, and induced abortion is the legal, or second one is the illegal. Mainly illegal is termed as the septic abortions. Then this is also divided, it is subdivisions also, that is the all isolated abortions and recurrent abortions are divided into 5 types. That is the threatened abortions, inevitable abortion, then complete abortion, missed abortion, and septic abortion. We will see the one by one in detail. Next slide. Firstly, we will see the etiology. What are the responsible factor for the abortions? First one is the fetal factor. So what are the fetal factor? We will see next slide. And second one is the maternal factor is equal to etiology. So fetal factor, there are genetics. 50% of early miscarriage due to the chromosomal abnormalities like trisomy, Edwards syndrome, then numerical defect like trisomy, polyploidy, monosomy, then structural defect like translocation and deletion and inversion of the chromosomes. Then if the multiple pregnancy occur, 1 or 2 childs are in womb. Then degeneration of the villi. Degeneration of villi means that this is the villi which provide the nutrition in early pregnancy. Then maternal factor. What are the maternal factor responsible for the abortions? Here endocrine and metabolic factors, that is responsible for 10 to 15%. Luteal phase defect and thyroid, if a mother having any thyroid abnormality and metabolism abnormality, this can lead to the abortions. Diabetic mellitus, then anatomical abnormalities like it leads to the 10 to 15%. And cervicouterine factors. First one is the cervical incompetence, means the abnormally dilatation of the cervix. and insufficiency. Then congenital malformation of the uterus. If the anatomical, any structural abnormality of the uterus is present, this can also lead to the abortion. Then uterine fibroids, any fibroids or benign tumors are present in the uterus, this can also leads to the abortions. Then intrauterine adhesions, any adhesions are present in uterus, inside the uterine cavity. So these all are the maternal factor. Next we will see the remaining maternal factor, that is the environmental factors. Then cigarette, if the mother taking smoking, like cigarette smoking, alcohol consumptions, contraceptive agents like, then maternal medical illness like cyanotic heart disease, mother have any cyanotic heart disease, hemoglobinopathies, and unexplained cause are the 40 to 60%. In majority, the exact cause is unknown for the abortion. Then next we will see the terms of the threatened abortions. So what is threatened abortion? Threatened abortion means it is the condition in which the miscarriage had started but not progress a state from which the recovery is impossible. So we can say that it is the reversible condition, and in this type of abortion we can prevent and prevent the abortion process or progress. We can progress the pregnancy and continuation the pregnancy. Here you can see the recovery is not impossible. Recovery is impossible means this type of miscarriage we can recover the patient and recover the baby also. So this is the term of the threatened abortion. Next we will see the clinical features. The patient having amenorrhea, amenorrhea means absence of menstrual cycle, then complain of slight bleeding per vagina, then pain, usually painless, and there may be mild backache or dull pain in lower abdomen. These all are the clinical features of threatened abortion. Then here the picture shows, here you can see this is the uterine cavity, and this is the placenta, and this is the embryo. There is slightly bleeding is present, but the cervix is competent. There is no dilatation of cervix is present in threatened abortion. So management or prognosis. So firstly, in threatened abortion, seeing the patient, what are the management we are doing? So first one is that we advise the patient for rest. Patient should be bed for the few days until the bleeding stop. Then we have to advise the patient. Then relief of pain, we will provide the patient diazepam 500 mg, the 5 mg b.ed. Then 80% of pregnancy that threatened abortion go on until term. Then if the fetus live in USG, pregnancy will likely to continue in over 95% cases. If the pregnancy continues, there is the increased frequency of preterm labor and placenta previa and IUG or intrauterine growth retardation. So this all are the management of the pregnancy. Sorry, management of the threatened abortion. Then inevitable abortion. Inevitable abortion means it is the clinical, it is also a type of abortion. It is the clinical type of abortion where the changes has progressed, but a state from the continuation of pregnancy is impossible. Means we can say that it is the irreversible condition. So what are the clinical features seen in this type of abortion? Firstly, the patient having the features of threatened miscarriage, present with the vaginal bleeding, then aggravating of cloacal pain in the lower abdomen. Cloacal-like pain patient feels, then sometimes the features may develop quickly without prior clinical evidence of threatened miscarriage. Then internal examination reveal the dilated internal os you reveal during internal examination, then through which the product of conception are felt. Then next we will see that this is the inevitable abortion. Image will shows here the embryo, then dilatation of the cervix or internal os is present, then some part of the conceptus products are out from the womb through the dilated cervix, and bleeding is also present. This is the inevitable abortion. The management is aimed to accelerate the process of the expulsion. We will not continue in this type of abortion, we will not continue the pregnancy, we will accelerate the expulsion process. Then to maintain the strict asepsis, then if pregnancy is less than 12 weeks, suction evacuation is done. And if the pregnancy is more than 12 weeks, expulsion of oxytocin infusion we will do. Then general measures, what kind of measures we give to the patient? Firstly, excessive bleeding is controlled by the administering methargine 0.2 mg. Then blood loss is correctly by the IV fluids or therapy or blood transfusion. So these all are the management of inevitable abortion. Then incomplete abortion, the term shows as the incomplete means something remain inside the womb. Then the process of abortion has already taken place, but the entire product of conception are not expelled out. Then a part of it is left inside the uterine cavity, means some part of the conceptive products are remain inside the womb. So this is called this called the incomplete abortion. So understood. Then next we will see the clinical feature. There the clinical feature history of we have to take the history of the expulsion of fleshy mass per vagina, then continuation of pain and in lower abdomen, then persistent of vaginal bleeding is present. Then internal examination reveals the uterus smaller than the period of amenorrhea. Then open internal os you will see during examination, then varying amount of bleeding is present. Then on examination you feel and you see the expelled mass is found is incomplete. If the inspect the expelled product of conception, that is the incomplete. Then complication, if the retained product of conceptus materials remain inside, it can lead to a bleeding, sepsis or placental polyp. So this is also this is the clinical features of incomplete abortions. Next we will see this image. Here you can see there is no embryo inside, but the placental product are remain inside the uterine cavity and bleeding occur, internal os is dilated. So this is the incomplete miscarriage. Then management, what are the management we will do in incomplete abortion? First we will do the evacuation of the retained product of the conception, and early abortion, dilatation and evacuation under the analgesia or the general anesthesia is to be done. Then late abortion, if the mother is late, then at that time we will do the uterus is evacuated under the general anesthesia and the product are removed by the ovum forceps and curettage and DNC occur to remove the beads of the placenta. Then prophylactic antibiotics are given because there is chances of the sepsis because some part remain inside the womb. Then medical management, what are the medical management will give? First is the tablet misoprostol 200 mg is used vaginally every 4 hours. Then complete abortion, the term is complete means completely the concepted products is out from the womb. When the product of the conceptions are completely expelled from the uterus, it is called complete miscarriage. So clinical feature, what are the clinical feature is seen? There is a history of expulsion of fleshy mass per vagina is followed by the subsidence of the abdominal pain. Pain is present and vaginal bleeding becomes truss or absent if the completely expelled out the product of conception. So sometimes we can say the absence of the vaginal bleeding is seen. Then internal examination reveals uterus is smaller than the period of amenorrhea. Then cervical os is closed and bleeding is truss. Then transvaginal sonography confirm the uterus is empty. So these all are the clinical features of complete abortion. Next one is a missed abortion. The fetus is dead and retained passively inside the uterus for a variable period, means the fetus is not alive and remain inside the womb. This is called the missed abortion. Means it is diagnosed when there is a fetus with the crown lump length of the 5 mm without fetal heart. The clinical features, the patient usually present with the features of the threatened miscarriage followed by the subsidence of pregnancy. Subsidence of pregnancy symptoms like nausea, vomitings are subside, but there is no pregnancy symptoms in missed abortion. Then uterus becomes smaller in size. Day by day it's growing, but in this type of abortion there is no growing of the uterus. Then cervix feel firm and closed internal os. In this abortion internal os is closed. Then non-audibility of the fetal heart sound, even the Doppler ultrasound. In Doppler ultrasound you cannot hear the fetal heart sound. Then immunological test for pregnancy becomes negative. In pregnancy test, here the pregnancy test is negative. These all are the clinical feature. Then what are the complications occur in missed abortion? First one is the retained product of long time can lead to the sepsis. Then DIC, disseminated intravascular coagulopathy. In this term, the clotted blood are going in the central vessels or central circulatory system, we can say. Then very rare in gestation exceeding 16 weeks. The management, uterus is less than 12 weeks. Firstly, what are the management we will do in this type of abortion? Firstly, we will do the prostaglandin E1 misoprostol 800 mg is given vaginally and repeated after 24 hours if needed. And expulsion usually occur within the 48 hour in this measures. Then suction, if this measure is failed, then we will do next step, that is the suction and evacuation. Suction evacuation done when the medical method fails. Then uterus more than 12 weeks, if the uterus more than 12 weeks, so we can do the 6th or 12th hourly misoprostol tablet given. And vaginally, if the fails, extraamniotic installation of ethadrine lactate is used, then antibiotic are given to prevent the infection. So these all are the management. Then next one is the septic abortion. Septic abortion means infectious abortion, we can say. Then any abortion associated with the clinical evidence of infection of the uterus and its content. Then most common cause of the attempt at induced abortion by the untrained person without the use of aseptic precaution. If any untrained person do the abortion without any knowledge of the septic, they can do. So these can lead to the septic abortion. Then there are clinical gradings of the septic abortion. First one is the grade 1. The infection is localized in the uterus. When the infection spread only the uterus, so it can be the grade 1. Then second one is the grade 2. The infection spread beyond the uterus to the parametrium and tubes and ovaries and pelvic peritoneum. So this is the grade 2 type of infection. Then grade 3 is generalized peritonitis, means the infection spread all over the pelvic organs or peritoneum layer also. Then this is leads to grade 3. Then this generalized peritonitis or the endotoxic shock, jaundice and acute renal failure also occur in this type of grade. Then grade first is the commonest and usually associated with the spontaneous abortion. So next, clinical feature. What are the clinical features of the septic abortion? Firstly, sepsis occurs, so the fever and abdominal pain and vomiting or diarrhea is present. Next, when the raising of the pulse rate, because of the temperature is raised, so pulse rate is also raised. So that is a pulse rate is 100 to 120 per minute or more is a significant finding. Then the even pyrexia, it indicates the spread of infection beyond the uterus. Then examination shows abdominal tenderness. If you feel that over the abdominal there is tenderness is present, the rigidity. Then internal examination reveals the offensive pleural vaginal discharge is present. Then tender uterus usually with the petalus and the boggy feels, soft cervix with open internal os. These all are the clinical features of the missed abortion or septic abortion. Then investigation, what are the investigation do for the septic abortions? First one is we will see the complete blood count, then serum urea creatinine, then electrolytes, high vaginal swab. This is what type of microorganism are present. Then blood culture and suspected septicemia, then pelvic USG and detect the retained product of the placenta. USG for it will see through USG we can see the what are the product of conception material remain inside. Then X-ray abdomen in suspected bowel injury, X-ray chest if any difficulty of respiration is present. So these all are the investigation for the septic abortion. So next we will see the complication of the septic abortion. So first one is the immediate complication. So what are the immediate complication? That is the hemorrhage, and the injury may be uterus and adjacent structure. There are some structure are present. They can also defected. due to the infection. Then spread of infection leads to the generalized peritonitis, means inflammation of the peritoneum layer. Then endotoxic shock, mostly due to the E. coli. And DIC, that is disseminated intravascular coagulopathy is present. Then acute renal failure can be present. Then thrombophlebitis. Then all this lead to the increase the chances of the maternal death. This is the immediate complications. Then management. First management is the mild cases. In mild cases, we will give the patient broad spectrum antibiotics, uterus and evacuated, DNC are done. Then in severe cases, vigorous IV fluid with the crystalloid solution, then oxygen given by the nasal catheter, because there is the chance, because due to the infection, the mother having breathing difficulty, so we will provide the oxygen therapy also. Then broad spectrum antibiotic combination of ampicillin, gentamicin, metronidazole is started. Then uterus is evacuated in 4 to 6 hours of commencing therapy with antibiotics. So this is the management of severe cases. Next, we will see the recurrent or miscarriage or pregnancy loss. Recurrent means one by one pregnancy loss. We will see the definition. Recurrent abortion. What is the recurrent abortion? Recurrent abortion is the definition. Is defined as the sequence of 3 or more consecutive spontaneous abortions. It is seen in 1% of all women. The risk will increase with each successive abortion. No underlying cause is found for 50% of recurrent pregnancy loss. So recurrent abortion means more subsequent 3 or more consecutive spontaneous abortion. This is the recurrent abortion. So etiology. First time in first trimester, what are the causative factors are responsible for the recurrent abortion in first trimester. Firstly, we will see the genetic factor. Genetic factor leads to the 3 to 5% cases. Then prenatal parental chromosomal abnormality. If parents having any chromosomal abnormality like Down syndrome or any other type of chromosomal abnormality like adverse syndromes, trisomy 21. Then the most common abnormality is the balance translocation. If there is genetic translocation is present, this can also lead to the first trimester pregnancy loss. Then this leads to the unbalanced translocation in the causing early miscarriage and live birth in congenital malformation. Risk of miscarriage in couple with the balanced translocation is more than 25%. This is the most common cause for the first trimester loss. So these all are the first trimester loss of the pregnancy causes of the first trimester loss. Then next one is the endocrine and metabolic. If mother or father have any endocrine abnormality like poor control of diabetic patient, then presence of thyroid and autoimmune antibodies, luteal phase defect. If female have the any luteal phase defect, hyper secretion of the luteinizing hormone. Luteinizing hormone is responsible for the ovulation. So if this hormones is secreted, this can also lead to the abortion. Then example PCOS. In PCOS cases, this is also responsible. Then infection in genital tract. An infection present in the genital tract like transplacental fetal infection, syphilis infection is present. Then inherited thrombophlebitis like protein C deficiency, protein S deficiency, factor V deficiency, lead-in mutation, and prothrombin gene mutation is present. So these all are responsible for the recurrent abortion. These all are factors. Then secondary trimester miscarriage. Second trimester miscarriage. So what are the causes of the second trimester miscarriage? First one is if female have any anatomical defect in the uterus or reproductive organs, are responsible for the 10 to 15% of recurrent abortion. Causes may be lead to the congenital defect in the Mullerian duct of the uterus, or the unicornate, bicornate, septate, or double uterus. We will see in picture in next slide what are the unicornate, bicornate, and septate uterus. Then acquired intrauterine adhesion. Any intrauterine adhesion is present. Then uterine fibroids are present if any tumors are present inside the uterus. This also lead to the abortion, recurrent abortion. The endometriosis means there is the abnormally growing of the endometrium layer of the uterus. Then cervical incompetence. If the in abnormally dilatation of the cervix is present is called the cervical incompetence. These all are the causes of the second trimester miscarriage. Then next we will see the second trimester or remaining part. Then anatomical abnormality responsible for the 10 to 15% of recurrent abortion. Then cause may be congenital or acquired. Means there are congenital cause like unicornate, bicornate, septic or double uterus. Acquired in uterine adhesions, fibroids, endometriosis, or any acquired infection or any abnormality is present during in reproductive organs. This can lead to the recurrent abortion. You can see here the image shows there are the septed uterus. Here you can see there is a septum is present, so the pregnancy is not grow, so the abortion occur. And here you can see double uterus. There are two Mullerian duct are present and two cervix are present. This is the double uterus. This is the structure abnormality or congenital abnormality of the uterus. Here you can see the histosalpingography showing the bicornuated uterus. Cervical next factor, next cause is the cervical insufficiency or incompetence. Cervical incompetence means the abnormally dilatation of the cervix, the painless cervical dilatation with the ballooning of the amniotic sac into the vagina followed by the rupture of the membrane or expulsion of the fetus. If the cervix is dilated, there are the amniotic membranes are come outside, so a balloon is created or any rupture of membrane is also occurred in this case. And usually at the 16, usually this occur in 16 to 24 weeks. So etiology, so congenital, what are the congenital etiology causes are responsible for this, that is the developmental weakness of the cervix, any congenital defect in the cervix, and the uterine anomalies are present. Acquired like the common following like DNC, recurrent DNC abortion operations are present. Then induced abortion by DNE, dilatation in evacuation. Then vaginal operative delivery throughout the undilated cervix. This is also this situation also leads the cervical damage, so it can be cervical incompetency leads in further years. Then the amputations of the cervix and the cone biopsy. Then multiple gestation are present prior to the preterm birth. These all are the causes of the cervical dilatation, cervical incompetence. Then prognosis of the recurrent miscarriage. The overall risk of the recurrent miscarriage is about 25 to 30%, the respective of the member of the previous spontaneous miscarriage. The overall prognosis is good even without therapy, but the chances of the successful pregnancy is about 70 to 80% with the effective therapy. So here we are completed the all type of the spontaneous abortion, and remaining the induced abortion is also we will see next slide. So thank you students, thanks to all for listening me. Thank you.